you regarding the predicting the surgical recovery and outcome in ERM as well as VMT surgeries. As we all know, 10 to 20% of the ERMs will have an unchanged or worse vision post surgery. So one need to predict what are the conditions which leads to poor visual outcome in these cases. The main and the relevant basic things one need to look at is one of the age of the patient. Lesser the age, better the visual acuity. The pseudophakic patients does well better than the phakic patients. Low baseline visual acuity, of course, a poor prognostic factor. Duration, especially if it is less than 1 year, the outcome will be better. Pre-op metamorphopsia score definitely tends to correlate with the post-op visual acuity. On OCT, look at the thickness of the fovea. The cystoid macular edema, if it is present, it is a poor prognostic factor. As we all know, the post-ERM peeling, there will be a ganglion cell reduction, which tends to correlate with the worst post-op visual acuity sometimes. INL thickness correlates with post-op visual acuity. The outer nuclear thickness doesn't have any correlation with the best corrected visual acuity. Does the pre-op macular contour contributes for the predicting the outcome? There are various pre-op macular contours will be there, either it's from a doom, flat or depressed type. The mean visual acuity gain was better seen with the dome shape preoperative macular contour than when compared to the flat or a depressed type. Early foveal pit recovery contour, definitely foveal pit restoration, early restoration correlates with best corrected visual acuity as well as the central foveal thickness and foveal avascular zone area. So it is one of the important predictive factors which helps in assessing the outcome in ERM surgery. There is an entity which has been described, which is known as in a Japanese word, which is called Tsukima. If you tend to say a clear-cut space between the ILM between the ERM and the ILM, these spaces, if it is present, it indicates a good prognostic factor and helps in a better surgical outcome. Another indices which have been described is what is known as inner retinal irregularity index, which is basically nothing but you measure the inner plexiform layer and the RP layer length of it. If you take the ratio of both these two, it gives the value of inner retinal irregularity index. This is a significant biomarker, the predicting factor, as the post-surgically, if you look at over a period of 6 months, the inner irregularity score increases and it tends to have a good outcome in these patients. Ectopic inner foveal layer, definitely it occurs due to the intraretinal gliosis and physical traction and leads to loss of visual acuity in many of the ERM patients. The thickness of the IFL, the ectopic inner foveal layer, basically it measured from the ONL to the ILM. So here, if you see an hyporeflective or hyporeflective band as indicated by this arrowhead, this indicates the ectopic inner foveal layer, which is associated with the poorer visual acuity gains depending upon the grade of ectopic inner foveal layers. There are 3 or 4 grades of ectopic, inner foveal layer has been described on a OCT based classification. 3 and 4 the grade tends to do poorly when compared to the grade 1 and grade 2. So stage 2, as I told, stage 2 ectopic inner foveal layers, they will have a better visual acuity outcomes compared to the stage 3 and stage 4. It is the presence of ectopic inner foveal layer is more important rather than the thickness of the ectopic inner foveal layers. Of course, one need to look at the outer retinal layers, that is ELM, IZ, the ellipsoid zone and interdigitation zone. Either they are assessed, look at it whether they are intact, whether there is a minor dehiscence or the disruptions or a major disruption, which tends to significantly correlate with the post-op visual acuity. Similarly, inner irregularity score, there is an outer irregularity score based upon the continuity or discontinuity of the outer retinal layers graded from grade 0 to 1 and 2. Like in this patient, they tend to have an intact all outer retinal layers. Here there is a disruption, so the reduced score, which tends to correlate with the visual acuity in ERM patients. If you look at the inner versus outer retinal deformation was relatively reversible post ERM removal, but outer retinal changes like cost line changes and other takes long time and may not recover sometimes post ERM surgery. The another entity which has been described is the photoreceptor deformation index. It is an indices measured at the center of the fovea and the paracentral area. You take a ratio of these things. This also tends to correlate very well with the post ERM surgery. On on-FOS OCT, the area of ERM, the contracted ERM is seen as a black zone, which is typically described as a zone. These are the radiating lines. This the size of the zone and other things, distinct plaque-like zone correlates with the visual acuity. Even the degree of stretched ILM lines adjacent to the ERM, if it is more, they tend to correlate more with the metamorphopsia score. So one need to look into these things on on-FOS OCT. The central bokeh abnormalities, it can be seen as nothing but a fovea cones thickening or detachment, which can be on various grades. There will be accumulation of widely formed materials like this, or presence of a subretinal fluid there. So these central bokeh abnormalities can be seen in any of the tractional maculopathies, including ERM. They tend to correlate inversely with ectopic inner foveal thickness, and cone bokeh abnormalities correlates with the worse visual function. The another entity which has been described is the disc fovea vascular distance. Basically, we need to measure the distance from the disc onto the fovea and from superior arcade to inferior arcade. This, if we can measure pre-operatively and post-operatively, we can calculate something known as tractional index of the membrane, which is nothing but a pre-operative distance baseline from the follow-up. So, if it is less than 1, it indicates significant membrane contraction. That's how you can assess the prognosis in many a patient. Of course, like in DME and any other conditions, drill, that is disorganized retinal inner layers, also serves as an important prognostic marker. The fundus autofluorescence, definitely yes. The baseline hypofluorescence sometimes associated with ellipsoid disruption. Hyperautofluorescence, there is a greater decrease in central foveal thickness without affecting the postoperative visual acuity. Octa definitely gives a clue in ERM, basically in looking at capillary distortions, changes in the FAZ. So basically looking at the vessel density, it's a positive prognostic factor if you look at these vessel densities, and they tend to correlate with post-op visual acuity as well as macular sensitivity. FAZ, as we know, there is in some cases post-ERM peel, there is a less expansion of the foveal avascular zone post-surgery. If such a scenario is seen, they tend to have a poor recovery, they tend to persist with metamorphopsia or anisoconia post-surgery. So one need to look at the FAZ size immediate post-op and the later post-op also. The another thing which has been described is due to distortion, you need to look at the linear vessel length as well as the branching distance once the contracture occurs. If you take a ratio of those two things also, which gives a predictive factor also. There are now with the choroid also seem to have certain changes in ERM, but the one significant factor is if you look at the satellus layer perfusion, which is a useful predictive marker in a patients with ERM. So another entity is, if you look at the choroidoscleral interface index, if you look at the choroid and scleral interface index, which also tends to correlate with visual acuity in many of the ERM patients. FFA definitely helps. If you see a vascular leakage in a patients with an ERM, they tend to have poor prognostic factors than in the cases which doesn't have a much leakage. So it is a very useful tool in helping the prediction of the. Then ILM dehiscence is associated with preoperative, postoperative increase in intraretinal thickness, and which is results in worse surgical outcome. Retinoschisis, because of the reducing the retinoschisis plays an important role in reducing tractional forces, hence helps in postoperative visual and structural outcomes are better in these patients. ERM with foveoschisis, the one thing is, if you see an ERM with foveoschisis, these patients tends to have a higher risk of postoperative macular edema, so one need to be careful in these patients with ERM with associated foveoschisis. PVD does not have a much impact on the postoperative anatomical or functional outcome. Intraoperative OCT, this thickness definitely helps in predicting the visual acuity. For if you got an access to intraoperative OCT, definitely yes. ERM, the eyes with shorter axial length associated with ERM tends to do poorly, especially in the initial post-operative period, but over a long term there is not much difference. If you see an AMD changes probably associated with ERM, they tend to have a poor prognosis. Eyes with the foveal herniation, what has been described with ERM, they also tends to do poorly in the immediate post-operative period. Multifocal ERG, no changes have been seen in amplitude, but one thing one should be careful is the amplitude and implicit time of positive peak significantly relates to the postoperative visual acuity. So the thing is, the age of the younger patients, lesser duration of symptoms, higher visual acuity at baseline, lower metamorphopsia score, and looking at the inner and outer retinal changes, and the absence of ectopic inner foveal layer, normal autofluorescence, and normal multifocal ERG, all these are good prognostic factors in ERM. The word about the VMT, as we know, many of the VMT patients have an anomalous PVD. So the type of attachment or an adhesion or attraction can have a outcome. For example, V or J shaped, what has been typically described, tends to have a different outcome. One have associated with a macular hole. One may get away with this. Smaller the VMT diameter and absent ERM sometimes leads to spontaneous vitreomacular traction release and a good outcome. and correlation has been there between the baseline visual acuity and resolution of traction. So one need to look at whether which cases progresses and which cases will have a spontaneous resolution. So you need to look into it. Thinner fovea baseline definitely has got a good prognostic factor with lower risk of progression to macular hole. So what are the poor prognostic factors in VMTs? One is if the disease duration is more than 6 months, the preoperative best corrected visual acuity is less than 20 by 200, preoperative thick central macular thickness, premacular fibrosis if associated with macular schisis and cystoid macular edema. Thank you. Thank you for your patient hearing.
Thank you, Sunil. Just to start on a couple of questions. Practically, when you look at your OCT, what do you think are the most important features that will help you detect a good functional and a good structural outcome?
Yeah, the one thing is if it is associated with the ectopic inner foveal layer, definitely it's a poor prognostic factor. The other thing is general factors on specifically since you asked for the OCT, inner retinal irregularity changes as well as the ectopic inner foveal are the two critical things, I think.
Yeah, that's for the poor outcome.
Yeah.
You had mentioned on Octa.
Yeah.
So, I mean, I have a doubt. Is there any role of the preoperative Octa? Because we know that it will be all bizarre, and the layers will be going.
Yeah, the many studies have variable results regarding the vessel density. The only parameter probably which may helps is the expansion and this thing of the FAZ, the foveal vascular pre and post
Yeah,
peel.
but
Huh.
even that will look
Yeah,
irregular and
definitely.
enlarged and all these things.
Depends upon the scanning pattern and the artifacts
Yeah.
also.
And one more thing, when you mention about ERM, lamellar macular hole,
Yeah.
it's always when to intervene and when not to intervene. Is there any OCT marker, other than vision and other things that will help decide surgery, the contour of the hole or anything?
The
Like
ERM with lamellar holes.
that? Yeah.
Yeah. So probably I'll combine both the surgeries, ERM with ILM peeling in such cases. But if it is depends upon the degree of lamellar hole the associated with, because if there is not much changes anatomically, probably visual outcome may not be affected much in these patients. Ma'am, your thoughts on that?
A very nice presentation, Sunil, very crisp and to the point. Regarding George's question, there sometimes we get epiretinal membrane with a lot of macular edema that you think that, why is this membrane having so much macular edema? Probably that is a point where a careful octa will tell you whether there was a vascular occlusion or something. You have to look beyond that central 3 millimeters, because if there is some evidence of non-perfusion or something in the periphery, it may give you a clue.
I just had a small doubt on. So one eye had a macular hole, other eye has a central bokeh abnormality, and the patient vision is 6/9. Will you operate on that patient? The other eye was lost to macular hole. The point, and I just want to know the parents.
Other is operated.
Other eye is not operated, but it's a large
Chronic-
CF1
chronic
meter.
hole.
Yeah, it's not going to improve at all. And this eye is 6/9 with central bokeh abnormality.
No, that all depends whether the patient is symptomatic.
Symptomatic 6/9, just symptomatic.
Yeah, 6/9 is not I mean, at least for me, 6/9 is not the criteria. But then if he's severe, I would give it a try, actually.
Yes, as told before, central bokeh abnormality is for severity and whether patient is symptomatic, what is the presenting visual acuity, many criteria will fit into that.
So most of it, the patient is symptomatic, and we saw CBA, and the other eye has a macular hole which is non-repairable.
So, symptomatic as in, is it a vision loss of 6/9 or is it a metamorphopsia?
She says that it is definitely reducing. I know, doctor, there is a difference between a couple of months back.
Okay. So if the patient demands it, probably, but there are reports of the CB abnormalities not changing over time.
Yeah, that's exactly
So
the point.
that is a point over there. So at 6/9, we still may have a role in convincing her to hold on for some time. That is not being so aggressive. But if there was metamorphopsia, that's a different story over there.
CBA, I mean, what I've seen normally is they do not complain of metamorphopsia, but definitely they complain of reduced vision from
So the metamorphopsia component would be by the inner retinal changes more. So the inner retinal, from starting from the outer plexiform changes, are more aggressive, but that would be a indication to operate. more than 6/6 to 6/9 vision drop, because a 6/9 vision drop you may not gain after surgery is the point over there.
But what if you could prevent a macular hole? My point was, you create a macular hole and then operate it. Is that better, or trying not to? I just want sir's
The
opinion as
CV
well.
abnormalities are a different pathogenesis than the macular hole formation. They're more of a slight pseudo-vitelliform deposition is more
Probably because of traction.
because of traction. Yeah.
And one more. Sorry. Yes. Go ahead, ma'am.
We very rarely see a macular hole having started from the central bouquet abnormality. I
Yeah.
think
So
we're
this is a
little,
real case scenario in my
yeah.
practice which I had. So that's why I just put up this
Give glasses and review after 3
3
months.
months. And one more thing, foveal schisis was associated with better prognosis. Sunil, foveal schisis was associated with better prognosis,
Yeah,
visual
but
prognosis.
that's what my
I-
thing is. If they're associated degree of one thing is the degree of schisis, the other thing is they tends to have a study shows that the post-operative thing is very critical because many of such cases post ERM peel tends to have a more macular edema. That's what they've shown. But retinoschisis is more protective. Overall diffuse retinoschisis when compared to the foveal schisis alone.
One last question. Would you go for a blanket ILM peel in all cases of ERM? Is it necessary?
Yeah. So, sir, yeah. So I'm just my topic is about the same, the predictive outcomes in macular after macular hole surgery. So often macular hole surgery is quite rewarding, but we're dealing with good vision, and there's often something to lose after surgery. So accuracy and knowledge is quite important here. So it is not only to take about taking the right or wrong decisions, but when a patient asks you whether he will get good vision, our most common answer is slightly vague. We just smudge it over there saying you're likely, but it is possible, but it is probable, and it is highly likely. All these things we say rather than giving definite outcomes. So no presentation on macular hole can go without this slide about the gas classification, which was done brilliantly without the help of OCT. The first question is that do holes close by themselves? So this was the answer. If you have a stage 1 with a VMT and a not full thickness, 30 to 50% of these type 1 and 1A holes could spontaneously resolve. But if it was a stage 2 or a stage 3, spontaneous closure was only seen in 10% of these holes. Once the vitreous connection is totally off, there is no reason for it to close after that. So how can you predict closure rates? Hole closure rates for any hole less than 400 microns is between 92 to 97%. But when it is more than 400 microns, the closure rate with the conventional classic surgeries come down. Again, as the stage of the disease increases 2, 3, and 4, the closure rates come down. So this was a fabulous study in 2014 regarding a high number of macular holes, and they showed that 3/4 of the macular holes are an improvement in vision. 81% had successful closure. But the things noted were that as the diameter increased more than 1200 at that particular point in 2014, which is slightly before the inverted flap era, the holes did not close, and 3.3 years were given as the mean beyond which operations were not attempted. But in a particular diameter hole, the more duration had a poor prognostic effect. So these slides are just to look at some of the things that we get mental pictures whether the holes will close or not. The first one, when it is flat, when it has no SRF, when it has no RSM, immediately our mind tells us that it's going to be a difficult case to operate. The second one has got RP changes at the base of the hole. Again, we have reservations regarding the outcomes of that particular hole. The top one is a hole that we think is going to close because of the characteristics. These are visual characteristics, a surgeon's instinct or rather. But there are good preoperative prognostic factors, of which the stage of the hole and the size of the hole are the most important ones. And the less duration of symptoms and a good preoperative vision are features that let us know that there is going to be a good outcome after surgery. But the most essential, simplest measurement is the foramen diameter, minimum foramen diameter or the minimum linear diameter measured parallel to the RP, the smallest part of the macular hole. There are quite a lot of studies which again tell us that whatever the other indices come, the best two indices are the minimal inlet diameter and sometimes the relationship to the basal diameter of the hole. This is a new closed study classification which they have added these 2 points in it. The hole size obviously, but the hole edge configuration, whether it is flat or whether it is a cuff of fluid, edematous edges, whether there is cystoid macular edema at the edges, the minimum height, that is the collapsibility of the hole. The greater the height, the more chance that it is going to close. The presence of a VMT and the presence of an ERM has been included inside this closed group classification. And there is a comparison of this classification, and the holes have been defined further: large beyond 400, extra large beyond 550, double extra large beyond 800, and giant beyond 1000. So for larger and larger holes, modified techniques including the inverse flap, the single layer ILM rollover, the temporal hinge flap, the ectopic ILM flap, viscoelastic, and as said in other anything that you can find, you can stuff into the hole. Now we are bored of holes, so we stuff into optic pits now. So that is the basic tendency nowadays. This study was good in a way that it showed us that closure rates with macular holes were high when they were medium to large, but extra large, the closure rates came down. But the closure rates were nearly 100% with the inverted ILM flap technique. So is it a big hurrah that we all start doing ILM flap techniques? We'll look at that later. There are many indices, of which the current index, which seems to have a lot of value, is a macular hole index, which takes into consideration the height of the hole. That is, how much tissue can collapse onto the center of the hole is also taken into consideration. These are the various measurements of the macular hole index, the trapezoid, the triangle. I'm not going to. This is a new paper which has come out, which takes into consideration the tissue around the hole and the cystic areas around the hole, and the MAI. This is by Dr. Ramesh Venkatesh, and he says that the macular hole area versus the total area. The total area is a trapezoid from the top of the hole to the base of the hole, which includes retinal tissue and the hole itself. This was an interesting concept beyond just hole closure. It's called the ELM gap, the gap between the external limiting membrane found out, which could possibly tell us whether the closure in a closed hole, how deficient are the outer retinal layers. So the ELM gap sign or the gap is also a measurable index which tells us more about prognosis. And here you see the ELM gap is high, and there it closes in a flat open configuration with a gap in the center. So this is our paper in which we've used something called the ELM angle. That is the angle between the ELM on both sides. And we got a cutoff level of 68 degrees. When the angle was better than 68 degrees, the ELM tended to close better. And when it is more than 68 degrees, the ELM gap was remaining inside. Choroidal hypertransmission could be just because of the OCT through the hole and increased transmission, but it also could be because of the RP degeneration, and it could be a unique biomarker feature to prognosticate holes. So these are some examples when you see there's increased transmission. The top one, there is tissue over there, but there is still transmission. The lower one, the transmission corresponds to the gap between the retina. NFAS, that is looking at the NFAS image. This is where you see the cystic spaces and around the macular hole. This is again is one of our studies in which we studied a manual segmentation, and we find that two types of cysts. In the outer retina you have more radial oriented cysts, and in the inner retina you have more speck cysts in a larger area. So the outer retinal cysts are in a larger area probably because of the loss of contact of the RP and the lack of functioning of the RP pump, while the inner retinal changes are more of a chronic nature and are in the Henle's elongated Henle's layer, and both of these were corroborated with preoperative visual acuity. We binarized this and found the areas and found that there was a correlation between the amount of the cystic area and the preoperative vision. Other good prognostic post-operative features include the integrity of the inner layers and the type of closure. Again, we know there are multiple types of closure. The best one is a type 1 without a defect, and the closure not only corresponds to whether the neurosensory retina is there, but whether the outer retinal integrity is there. Again, these are the type of closures explained, and also the ellipsoid zone integrity, grade 0, grade 1, and grade 2, and obviously the integrity is a main factor for the post-operative visual acuity. This is called a lucency, where you see a small gap despite a closed macular hole. So other features that we find after surgery are the Sandfeld, which is a temporary phenomena because of the surgical trauma, and Dornfeld, which is more associated with ILM peeling, probable amount of dye toxicity and air infusion stress, where the changes are a bit more. There is a loss of the Muller cell plates, and this is beautifully demonstrated as hexagonal circumferential in the area of the ILM peeling on an NFAS OCT, corroborating with a low with microperimetric changes in these particular areas. So I'm just going to skip these because these are not. Let's talk about the ILM flap. Even though it's a panacea to show the patient you've closed, it is a negative biomarker. When you have a plug, there is no retinal tissue. The visual acuity is less than when the macular hole closes with a classic ILM peel. Therefore, our tendency to go towards the ILM flap should actually be reducing and not. We have stopped thinking about which holes can close with a regular classic technique, and we do the inverted ILM flap for everything. So this is some of the examples of how the flap, which is essentially not neurosensory tissue, closes the defect. The restoration of the outer retina is something important, is that a good ELM restoration precedes the ellipsoid zone restoration. So the ELM closing is one sign which could tell you in the early post-operative patient period that this patient could get good vision back. As I said, the easy disruption, there is a horizontal value and a area. The preoperative vision is associated with the horizontally measured area, but the postoperative vision is an NFAS measurement of the EZ area. I'll just show you in this slide. You can see this particular slide. After the hole closed, there is still this much ellipsoid zone disruption, and this is responsible for a poor visual acuity after surgery. This is another thing that we studied, is how the fovea moves after surgery, and we found that both the fovea can move temporally after macular hole surgery, and it can move nasally towards the disc, and this could be related to a poor visual acuity. So this is how we measured. We found the preoperative and we found the metamorphopsia is more associated with the intraretinal cysts, and that could be an indication for estimating the metamorphopsia after surgery. So to summarize, basically we have a lot of features. The preoperative features include the basal linear diameter to be the most important. There are various indices. The postoperative are mainly related to the outer retinal integrity after the surgery, the presence of the ellipsoid, the interdigitation zone, and the photoreceptors. So to conclude, macular holes are neither simple nor are they lost causes. You need careful case selection, a good preoperative OCT to give you clues, and you will get anatomical results. The only thing I'd like to stress is that let's not be too overzealous with the new techniques of inverted ILM flap or stuffing whatever we get inside the macular hole. Communicating with the patient and not giving over enthusiastic results may be important. Thank you very much for that. You can take the questions later also.
When do you decide to change your routine technique? And based on any of these, what would be the best parameter that you look at, and when do you decide to change the routine ILM?
So I have stopped trying to see. Basically, I'm trying to do more and more classic peels nowadays. So previously, that's all we did, and we had closures. So my range of classic peels suddenly, instead of inverted flaps, we're going down to 400s, for 500s. I'm still doing classic peels. And even when I do the inverted flap, I'm trying to do only a temporal hinge, where the concept is not filling the hole; it's just covering the hole and causing a immediate tamponade after the surgery. So that creates a better sliding of the neurosensory. It's like a combination of the classic peel with just a small thing. So those are the things I'm trying to do in cases where I am compelled to give a good anatomical result after surgery. The ILM goes inside the macular hole.
Now, when you do the temporal flap, you remove the nasal.
I remove the nasal side. It's nearly like a classic, but
there is
only
left on the temporal.
Only left on the temporal side. Thank you. That was an ROC curve, region area under the ROC curve. So it showed a cutoff area of 68 degrees. So there was a huge number of patients in which we did the ROC curve. On the area, this was the peak at that area. Just introduce me.
Next talk will be by Dr. Muna Bende ma'am. She will be talking on predicting the progression of dry AMD and how the imaging can help us in dry AMD cases. Madam needs no introduction. She is a senior vitreoretinal surgeon from Shankar Nethralaya. Over to you, ma'am.
This one? Do you have a pointer? Yeah, good morning, everyone. Thank you, Uni, for inviting me to this session, and thank you for everyone who's chosen to spend their Sunday morning here with us. Uh, what we're going to try and find out in the next few minutes is how do we change or how can we recognize the evolution of geographic atrophy from at risk to atrophy in the spectrum from normal aging to atrophic AMD. There has been this recent publication on prevalence and pattern of geographic atrophy in Asia, and we thought we knew it all that geographic atrophy is not so common in Asia as it is in the West. We were equally proud to see that there were so many studies from India, including from our own, a little confused by that number, which shows that some of the cases have a higher incidence. And then when you read the entire article, you see that many of the Indian data was not even included in the final analysis due to various reasons, the way of access, the time of evaluation, and also they felt that some of the cases were outliers. So this may not exactly tell us the real picture of geographic atrophy. The Edward Memorial Jackson lecture was given by Dr. Emily Chu, and she has this interesting table which shows us that as the number of known risk factors increases, like age, education, smoking, baseline AMD severity scores of the study eye and fellow eye, and the genetic risk factors, you see that the the C index goes fairly high, almost up to 1, which is believed to be of significance. And the large UK cohort also showed us that importance of the fellow eye. Supposing you have, I'm sorry. Yeah, this is the study eye and the fellow eye. And if you look at the condition of the fellow eye, you see that the increase in progression to geographic atrophy increases as well. And this is an interesting paper. It says September 2023. I was a little confused as what was the year we are in, but probably this is a preprint. And it shows us there are various risk factors in terms of incidence of geographic atrophy and expansion of geographic atrophy. Certain risk factors are shared, certain are not shared, certain are uncertain, and some of them are exactly in the opposite direction, which indicates that we have a lot to learn as far as progression of geographic atrophy is concerned, and more of interest because now we have the complement inhibitors which are being studied and getting FDA approval as well. The RH2 had an ancillary SDOCT calculator for risk of AMD, and it shows that there was one single factor that was important, both in terms of new onset central atrophy and new onset geographic atrophy, and this was the presence of RP layer atrophy or absence. If it was present at start, the risk of atrophy was higher than if it was absent at the start of the study. We know these are the precursor lesions, but how long do they take to reach geographic atrophy? Hypopigmentation, surprisingly, is the shortest, whereas large confluent drusen, which is something we all recognize, takes almost about 6.5 to 7 years before it progresses to geographic atrophy. And these are the various imaging protocols that we now use. Color fundus photography, which is okay in pigmented eyes because we can recognize it well. Fundus autofluorescence, we all know we are able to recognize atrophic changes with loss of FAF and study of the junctional zone. Near infrared reflectance, and now there's a lot of importance on OCT because it is able to show us choroidal hypertransmission very well. And the atrophy study group, the multimodal imaging of non-neovascular age-related macular degeneration, showed that there was a grading of atrophy. Here it goes in reverse, where D1 is the earliest sign when there's incomplete loss of outer layers, moving on to the most extreme, that is A1, complete RP and outer retinal atrophy or CRORA. And what most of the studies now try to do is stop the conversion from incomplete to complete RP and outer retinal atrophy. They also demonstrated the junctional zone between the area of atrophy and the normal area. They found there were three patterns, and the irregular pattern and the splitting here, where you have some intact areas, some split here, these are the two that were at higher risk of progression to atrophy. What else can we do? You have to look very carefully at the OCT, and you find that changes in internal reflectivity of the drusen, here you see it is a little high reflective as it moves further. There is a low reflectivity of the drusen. Outer retinal hyperreflective foci, these are high risk for progression to atrophy. And outer retinal tubulations, though we take it as a negative biomarker, is actually believed to be a protective factor when it is at the edge of the lesion. These are some of my own cases. Here you see this patient, you have some hyperreflectivity here, you have choroidal hypertransmission, and over a period of time you see there is atrophy. And this is another location, the same patient, this is another area where you see development of hyperreflective spots in the outer layer overlying the drusen, and you see over a period of time the drusenoid PED enlarging in size, it becomes larger and then it flattens down. This is another eye showing a little bit of hyperreflectivity that flattens down after a year. So these are changes that may be there somewhere in the fundus, and you need to have a careful OCT examination. What is more important is recognition of autofluorescence patterns at the junction of atrophy and normal retina. And these patterns of banded autofluorescence, where you have hyperautofluorescence around the lesion, or this branching or trickling pattern of autofluorescence indicating widespread outer layer disturbance, are more at high risk. This is another patient of mine. You see, this is when the patient started out, and this is the B scan OCT showing this intermittent, interrupted pattern of disruption of the outer layer, choroidal hypertransmission. You see a couple of years later, there is a definite increase in loss of autofluorescence. But you look at it 2 months later, it's not changed. This indicates that geographic atrophy is slow to worsen. It doesn't happen overnight. And this is again the fellow eye of the patient. You see the small area of atrophy. Look carefully at the border. This is what I meant as the branching or trickling pattern of hyperautofluorescence at the border, indicating that this patient has a higher risk of progression of geographic atrophy. And this is 1 year down the line. You see this area has increased from here to here. So these are the various patterns of imaging patients with geographic atrophy, and these are the high risk factors. You have larger areas of geographic atrophy, multiple areas of geographic atrophy, an irregular or a multifocal configuration, extrafoveal geographic atrophy. All these have high risk for progression. And you have the area of banded or trickled hyperautofluorescence at the borders. Another condition we are able to notice the area of choroidal hypertransmission. We've seen it on the B scan images. You can also see it on the ANFAS image. And in this study, they show beautifully the area of increase of choroidal hypertransmission that occurs over the years. We did talk about vitelliform lesions and how important they are. We should know that vitelliform lesions are avascular. As you see here, this is an acquired vitelliform deposit in a patient with AMD. Over a period of few months, this flattens and becomes atrophic. This is another patient where we see hyperreflectivity on the surface of drusenoid PED gradually increasing with time. Forgive me because the plexilite goes in reverse. So you see here the areas of hyperreflectivity on the surface of the drusen, and you see now at almost 3 years down the line, the whole thing has flattened out. So once you see those changes on the surface, don't get confused that it's neovascular AMD. It's just a precursor of geographic atrophy. Sometimes you find these little caps of fluid on the surface of a drusenoid PED, exudation from an avascular PED, and this is also an indication that the PED is eventually going to flatten down, as what happened in the left eye of this patient, and the right eye followed suit another year later. It's a very elderly person with geographic atrophy, and you see over follow up the area of the drusenoid PED increasing with size. You see the same thing happening in the left eye. It becomes larger and eventually flattens out. So, increasing size of the PED and presence of hyperreflective dots on the surface are not indicators of neovascularization. It could be that, yes, it is going to flatten down eventually, and it usually takes about 4 to 5 years for this to happen. This is a patient with a very long follow up from the year 2007. You see, there are periods where he had evidence of fluid on the surface of a large PED which was growing in size, no evidence of neovascularization. Look here, there are small, I just take a couple of seconds more. There are small areas of discontinuity and hypertransmission on the surface of the pigment epithelial detachment, which is not a rip because the configuration is maintained. And over this 12-year period, you see he had multiple episodes of ripping and flattening of the PED, and now 12 years down the line is a totally area of atrophic retina. So pigment epithelial detachment can behave in very different ways. I will just end now. Sorry. Another risk factor is patients with early onset large drusen. You may see a patient at age 30 with large drusen. This is not AMD, these early onset large drusen, but they can have geographic atrophy very much earlier. So these are the lesion characteristics identified as prognostic for geographic atrophy progression. High evidence is a larger baseline lesion size, multifocal lesions, perilesional autofluorescence patterns, and non-foveal locations. There are higher progression rates, greater extent of abnormal higher fluorescence, which are areas which are of moderate evidence. And I'll just end this. I love this comparison of geographic atrophy incidence versus progression, and comparing it with Charles Dickens' story of A Tale of Two Cities, where there are two sentences. We know that I tell thee, said Madame, that although it is a long time on the road, it's on the road and coming. I tell thee, it never retracts and never stops. I tell thee, it's always advancing, which is what we think of geographic atrophy. But what we want to know is the answer to this question. It does not take a long time to strike a man with lightning, but how long does it take to make and store the lightning? And hopefully by next AIOS, we'll have some answer for this. Thank you very much and welcome to Chennai in June.
Ma'am, can I have one question? Ma'am, regarding the patient with the very long follow-up. So once it developed the sliver of fluid on top of the PED, so what did you decide to do at that point in time?
Actually, nothing, because patient had FFA and ICG. We knew that there was no neovascular component, and you can see those RP apertures, which is now something that you see little breaks on the surface, or you see that RP is getting degenerated. You see a change in color on the surface. There's pigmentation. So you know it's not neovascularization. This was unusual because every time he ripped, that thing would go down and then it would come up. Now there's nothing left to rip, so I think it's stable.
As an extension to what he asked, in that scenario, I hope you remember the case which I recently presented. We had two scenarios, one with fluid and SREM, fluid and vitelliform. So in the case which I presented, I mean, ICG didn't pick up the. I mean, what do you think is the role of octa in these lesions?
Now I would be doing octa, but if you see, this was 2007.
Yeah.
And I'd use the colored image. Yeah. Now I would probably do octa, look a little carefully, but usually fluid on the surface. And there is a recent publication, I think RCBR this year, which tells us that these apertures are precursor to geographic atrophy.
Yeah, because the case which I had a normal ICG, and the manual I showed sub-RP segmentation showed a flimsy membrane there actually. So I do agree with you on the role of octa and manual segmentation. Just in case the mimicker may have a subtle membrane, unlike the cases which you presented.
And also the second case of the acquired vitelliform. Actually, I had done an octa. I think I picked up a segmentation artifact. I do not know. I thought that I would give an injection. Then the gentleman said, let's think about it. And then he came back and the whole thing had flattened. So I think in acquired vitelliform, a little difficult to, we may end up over treating because of the segmentation artifacts.
There's another scenario where instead of the PED, you have fluid associated with just geographic atrophy. I mean, obviously, these are cases, again, we call them non-neovascular SRF. But in the presence of geographic atrophy, saying whether octa there is a membrane or not is extremely difficult. Are there any clues or tips by which we can diagnose that?
A cystic space directly over an area of octa of geographic atrophy, then I wouldn't worry much. But if the cystic space or the fluid is away from the area of geographic atrophy, then I would be worried. In fact, one of the patients I didn't show for lack of time, he developed a CNVM at the edge, whereas this area eventually flattened. So I think it's where the fluid is.
On the autofluorescence which you showed, beautiful images with the descriptive of geographic atrophy and its progression. Is there any way where you can quantify? How do you, the progression? Is there a way of measurement or quadrant wise? Is there any way of looking at that? Just that qualitatively enlargement, but that takes a long time. Is there any thing that
I think quantitative autofluorescence has begun, but I am not sure how much it has taken up. It is possible to measure the area. There is quantitative autofluorescence. I think not yet reached its popularity. Probably not, maybe not, you cannot replicate it every time. So.
You can use calipers to measure it. You can just use, if you are measuring the area, you can easily use calipers and measure the area of autofluorescence and document it. Yeah, autofluorescence can be measured. In fact, they have tried to measure it on the OCT also, but the OCT is more difficult to measure it. It gives you it quickly. Yeah, but the measurement which has been done by the CAMS group, I think it has been done on autofluorescence. And if you can't do it on your image analysis thing, you can just export your images to the J-image protocol and you can measure.
This is that similar conversion to image J. I think the slide hasn't come. Okay. So we can do it. You can use the freehand tool to measure the area.
Thank you, ma'am, for that great talk on quite a difficult but really interesting topic. I'd like to invite Dr. George, who is from the Aravind Eye Care Systems from Coimbatore, a keen retinal imaging specialist, a great surgeon, a good friend, and a very analytical mind also. So his talk is really going to be full of facts and proof. Thank you.
Thank you, Unni, for your kind words. And let's look predicting visual outcome in DME with some of the. I would be stressing on the non-invasive, octa or OCT biomarkers, which helps us to predict the visual outcome in DME. So basically, the OCT include central subfield thickness, drill, hyperreflective, choroidal and retinal foci, external ellipsoid zone, and choroidal thickness and parallelism. So it has been known for quite a long time. The central subfield thickness, central 1 millimeter on the OCT map, has been from the earlier time onwards, increased baseline thickness is predictive of visual acuity, and most of the studies have looking at this biomarker to predict the visual and anatomical outcomes and change in thickness, predicting the visual acuity change. But some of the studies like protocol A of the DRCR and all showed that there is only a modest correlation between vision and baseline thickness, and also with focal laser in protocol A, there is a modest correlation between vision changes and changes in macular thickness. And we know that many maculas with thickness, excess thickness have good vision, and vice versa. So there is a paradoxical visual acuity. So OCT could be central thickness only good anatomical surrogate and not a great predictor of visual outcome. And protocol T with anti-VEGF therapy also showed that at best there is a modest correlation between vision changes and changes in macular thickness after anti-VEGF therapy. So central subfield thickness on OCT is a useful anatomical surrogate for diagnosis and treatment of DME currently, and not an accurate predictor of vision. So the other the OCT subtypes like diffuse thickening, cystoid edema, serous macular detachment, tractional or a component of epiretinal membrane. So earlier studies had shown that CME, the cystoid spaces, have worse outcome than serous macular detachment and diffuse thickening. But actually it's not the presence of cyst, but the size of the cyst, more than 200, and presence in the outer retina, outer nuclear layer, and more importantly the remaining foveal tissue. That is these bridging retinal processes which transmit the impulses from the photoreceptors to the ganglion layer. That is especially the Muller cells and bipolar cell. That is more important than measuring the cyst size and the location. So bridging process is a positive biomarker. If it is intact, you can predict a good visual outcome in these patients. And serous macular detachment as a subtype of DME usually happens when there is an external limiting membrane disruption, and supposed to be a favorable visual outcome if you see at the baseline this finding. But it is also suggested that presence of increased interleukins and active inflammation. So it is suggested that DEX implant would work much better than the anti-VEGF therapy, especially when you have serous macular detachment in the presence of multiple hyperreflective foci. So there is no consistent data as to these subtypes of DME on OCT regarding the prognostic significance on visual outcomes, though there are suggestions as we mentioned now. Coming to hyperreflective foci, these are precursors of hard exudate, not hard exudate seen on clinical examination less than 30 microns, and usually the lipid extravasation or the activated microglia, which suggest a role of inflammation in the presence of multitude of hyperreflective foci, and suggests that it's a more severe DME and associated with poorer vision at the baseline. And corticosteroids rather than anti-VEGF, because of the inflammatory component in this, would be better than anti-VEGF therapy in the presence of many hyperreflective foci. So outer retina, when hyperreflective foci, it has been correlated to the disrupted ELM and ellipsoid zone, and hyperreflective foci can be seen in choroid as well, which is a prognostic marker, poor prognostic marker for visual outcome, and is more associated with later stages of diabetic retinopathy like proliferative diabetic retinopathy. And drill, as we all know, is a disorganization of the inner retinal layers, and when it happens in the central 1 millimeter zone, where the linearly you cannot differentiate the inner retinal layers, drill is present, and centrally located drill, that is within the 1 millimeter, more than 50% drill is suggestive of poor visual outcome if you are treating the DME. And every drill increase by 300 micron is also shown to be predictive of one line drop after 8 months of follow-up or treatment of these patients. So more than the baseline drill, the drill extent change is a robust predictive biomarker in DME, and more robust than any other SD-OCT parameters or biomarkers, and could be considered in the future therapeutic trials rather than central subfield thickness as biomarker for anatomic and visual acuity outcomes. So the next is ellipsoid zone. We know that it's a plexus of Muller cells and photoreceptors, and the disrupted ellipsoid ellipsoid zone usually goes along with external emitting membrane disruption, goes along with ellipsoid zone disruption, but ELM disruption happens prior to the ellipsoid zone disruption as in a timeline, if you look at, and is a useful prognosis when you treat DME. And this ellipsoid zone or ISOS junction is actually showing disruption of the macular photoreceptors, and the percentage disruption of ellipsoid zone helps clinician to more accurately predict the visual outcome when you are treating DME. So as I mentioned, the grade 1 is only ELM disruption without ellipsoid zone disruption, and grade 2 has ellipsoid disruption along with ELM disruption. So these correlate with the logmar visual acuity as well. So coming to choroid, when you do an enhanced depth imaging, many of the DME is seen to have thinner choroids, and if the patient is having a baseline greater thickness of the choroid, we expect a better anatomical and functional outcome, because the choriocapillaries supplying the outer retina is better, and you expect a good outcome if you have a patient who has a baseline good choroidal thickness. And parallelism is nothing but the subfoveal area of the photoreceptor is segmented and skeletonized, and usually in a normal situation it will be parallel, and in DME it is all disrupted, and loss of parallelism is again a biomarker correlating with visual acuity in diabetic macular edema. So now coming to another important aspect on OCT, which suggests these are intracystic hyperreflective material, or ICHRM, is a good is a poor prognostic indicator if you have in the baseline, because this suggests a chronicity of edema. This can happen in RVO or other vascular retinopathies, and minimum 7 months for it to form, and visual acuity is generally poorer, and more number of anti-VEGF injections, as well as it has been shown more number of steroid injections as well. There is no particular benefit of steroid injection if at all in this case. So these are the if you see this biomarker, it's a negative biomarker to have. As well, another negative biomarker is the presence of ERM or taut posterior hyaloid phase, usually associated with recalcitrant macular edema. Coming to OCT angiography, the generally and most commonly what we look is the enlarged foveal avascular zone, but this primarily happens in the deep capillary plexus. Later it involves a superficial capillary plexus. So if you have a slight enlargement only in the deep plexus and superficial plexus is intact, that patient might benefit with anti-VEGF, still with intravitreal anti-VEGF therapy. So the superficial plexus involvement comes later, and the FAZ size on OCTA has been correlated with presence of drill as well, and is a negative predictor or biomarker for the management of DME. Another OCTA biomarker is the reduced retinal vessel density. It's a ratio of blood vessel area versus total measured area on OCTA, and again it is seen both in superficial and deep plexus, and a negative biomarker. Intercapillary spacing is more sensitive parameter than vessel density and foveal avascular zone size in predicting early capillary dropouts in DME. More sensitive indicator, intercapillary spacing. And to touch on fractal dimensions, these are the geometric arrangements of the retinal microvasculature, and as you can see, it's lost in the presence of DME. Again, reduced in both superficial and deep capillary plexus, the loss of fractal dimensions, and usually in the setting of pregnancy or renal patients, now OCTA has turned out to be the tool of choice for evaluating the foveal perfusion in these days. To sum up, the negative biomarkers which predict poorer visual outcome other than central thickness, it's a presence of drill or the drill change over time, larger cyst in the outer retina, ellipsoid zone disruption, hyperreflective retinal and choroidal foci, and ERM or taut posterior posterior hyaloid. And if you have a subtype of serous macular detachment with intact ellipsoid and bridging retinal processes and higher subfoveal choroidal thickness, you are looking at a patient who would respond well to your treatment in DME. So OCT octa biomarkers helps not only in grading the severity of the DME but also predict visual prognosis and helps to modify our treatment regime accordingly. Thank you for your kind attention.
Thank you very much, George, for very wonderful presentation, very nice and crisp. I just wanted to ask you, what about looking at the periphery, wide field imaging? Would ischemia in the periphery be
Yeah,
somewhere in
definitely.
that?
If you
Yeah.
have a when you have a suboptimal responders to the initial therapy in the presence of, if you're looking at your question is pertaining to when you have a non-proliferative diabetic retinopathy with
Non-proliferative retinopathy, but macular edema not responding,
yeah.
and you've taken out everything else. Would you be looking at ultra-wide field
Yeah,
FFA or
yes,
some?
yes, definitely wide field, and probably to look at the with suboptimal response, first thing that we look at is perfusion. If you find other than all these intracystic hyperreflective material and other biomarkers, look at the perfusion in the periphery. And though the studies have not shown the targeted laser as a blanket treatment, but in this subset which you are pointing, there is a definite role in covering those areas. And not only in other vascular retinopathies, like when we have branch vein occlusion, or I think when we have a suboptimal response, the peripheral non-perfusion definitely needs to be tackled, so it becomes more responsive. Now with the wide field octa also might help in that regard, if you have a quite a big area being covered.
And yeah, yes, Tindula.
In ICHRM, do you feel statins have a role to play?
Pardon?
Statins.
I mean, the so far the evidence that we have, there are different mechanism that is postulated. Statins, I do not know. I don't have any, and even I don't find any evidence to support, or I don't have any personal experience on statins. But then there is a lot of speculations made why this happens nearer to prominent microaneurysms. Is it a leakage from microaneurysms? Is there a increased permeability that is causing these formation intracyst? But whatever it is, I mean, there is no consensus on what, and the studies have shown that this happens not in the beginning. When you see DME, they are not there. While you are treating or observing or treating these patients, these materials get probably lipids or material gets extravasated, and then it becomes difficult to treat these patients actually.
One other biomarker that I would think of is more neurosensory detachment, less intraretinal fluid, in which case you'd probably want to look at the blood smears to see whether the patient has hypergammaglobulinemia or
Yeah.
multiple myeloma, because these are very common.
Yeah, actually,
So,
one beautiful study from your center have actually shown in the presence of predominant serous macular detachment than the other subtypes. Very important to look at the systemic parameters, where deranged renal parameters, uncontrolled hypertension, and lipids, and higher HbA1c has been correlated as the only, on multivariate analysis, these were the factors which are correlated. And so hence the recommendation is to do a systemic analysis while you treat the patient.
Thank you, George, and thank you for that wonderful talk. And I'd like to invite Dr. Parveen Sen, who is from working as the senior consultant at Agarwal Eye Hospital, Chandigarh. Madam is a expert on retinal imaging and pediatric retina, and she will be talking to us about predicting treatment response in exudative AMD and its variants.
So thank you, Ni, thank you for the invite, and it's always a pleasure to be a part of this course.
setting.
पहले
अरे ऐसे नहीं होगा सेटिंग में जाओ ना
you want me to put it on my pen drive?
डिस्प्ले
If anyone has any questions while Parveen is getting ready. Any comments?
इस पे जाओ ऊपर हाँ सबसे लास्ट रन करो पीपीटी
Done. Yeah, done.
भाई पीपीटी ओपन कर दो
PPT open है.
फुल स्क्रीन करो ना
Because we have time, let's start. Peripheral ischemia and non-resolving diabetic macular edema. There's been varying reports in different studies, isn't it? So can we really come to a conclusion regarding the same?
I have it on my
I
pen
don't
drive
think so,
also.
isn't it?
Only
If you see a non-responding edema and you see
Put it on
peripheral
the other one.
capillary non-perfusion area, we try to laser. But does that really help? I had done in a couple of cases, wasn't that beneficial as well?
वही डाल दो
No, actually, if you look at the evidence, actually it says that there is no difference between when you have this targeted laser to those ischemic areas. But then when you treat the patient individually and you find that the recurrence happens even before the drug goes away from the eye, then you get a clue that this patient must be having, in those particular patients, especially when you look at these RVOs, BRVOs, and I feel that is more pertaining to those patients,
occlusions, I see.
occlusions than DME. But then even DME patients, if it is a anti-VEGF response is less, then I would do that. At least in a subset of patients, it works.
Yeah, Parveen.
Yeah, so good morning, everyone. And without wasting any more time, let me start the presentation. So, we are looking at prognostic markers for response of disease in AMD. So, how do you define response? Just a couple of slides on that. So, it could be a functional or a morphological response that you look at. So, functional response usually assessed at about 4 months after 3 monthly injections have been given. Poor response is no change, non responder is drop in vision, and suboptimal or a good response is probably a gain of more than 5 ETDRS letters. And in terms of a quantitative response on OCT, a better than 75% decrease in IRF, SRF, and CRT is a good response. Anything less than 25% decrease is an inadequate response. And before you label anything like a recalcitrant CNV, the definition is that after 6 intravitreal injections and less than 30 days of the last injection, if your patient still has persistent or a refractive, then you will name it as a recalcitrant CNV. So we all know these are the most common manifestations of persistent disease, the IRC and the subretinal fluid. So other than that, what else can we look at? The predictive markers of response once you have started treating. So various algorithms have been formed to look at and what are the factors that have been considered. Some epidemiological factors like age of onset. So later the age of onset, the worse is the prognosis, the longer the duration of disease, the worse is the prognosis. Better visual acuity at baseline, patients do better.
And if the patient has a poor vision to begin with, response is not so good. OCT based parameters, most easily accessible is the central retinal thickness, but the central retinal thickness variability will determine the prognosis. So if the variability is fluctuating, increasing in thickness, decreasing in thickness, anything thicker than 425 micron, poor biomarker. If it is very thin also, it's a poor biomarker. CNV size. So smaller CNV, good prognosis. Larger eyes or larger CNV, you have more chances of drop in vision. Type of CNV. So type 1, or rather we should say type of MNV. So type 1, better visual acuity, but as you treat, the collapse of type 1 causes geographic atrophy, so initial benefit may become lesser. Type 3, we all know they progress very fast and can result in macular atrophy very soon. Just an example that within 6 months, what was just a drusen earlier, this has progressed to a full blown type 3 MNV, and you can see a large PED with under the PED there is a vascular growth, and this is how it looks on a multimodal imaging on Octa. And this is the other eye of the patient, so you can see the regression is there, but it has resulted in atrophy, so it's a poor biomarker as well as as far long as the vision is concerned. Subretinal fibrosis, nearly 1/4 of the eyes can have fibrotic scars, and this fibrous tissue generally resilient to anti-VEGF treatment, more commonly seen in type 2 and type 3. And this subretinal hyperreflective material, if present, can definitely increase the rate of subretinal fibrosis. You could have vascular or avascular Schrem. Vascular Schrem means already there is a type 2 component which has come up, and now there is you can see the flow is present, and this is what is suggestive of a type 2 component which is present. And another case of subretinal fibrosis, you could see a large whitening area here, but when you see the OCT, so this is the type 1 CNV, but this whole area is that of a Schrem. So this is not usually very often seen, but when it is seen, it is a poor prognostic marker. You can see after multiple injections, it has come down, but it is not improved visually also so much. Only improvement is 660 to 624. And when you do Octa in this patient, you see it has got some well-formed large trunk, so it's a resistant kind of a CNV which is present, and it's a large network also which is present. You could have subretinal fibrosis in various places, and how would you decide which one to treat, which one not to treat? So this is a lot of subretinal fibrosis, but hardly any subretinal fluid. This membrane has subretinal fibrosis, scarring, but still some amount of fluid is present. I would probably still give a trial of anti-VEGF and see if the vision improves. And this again, ORT. So these are the signs where when you know that the vision may not improve. So this has to be probably a lesion which may not benefit by treatment. IRCs above these scars are usually may not be an indication of treatment. Again, large cysts overlying the disciform scar, also not really patient is not going to benefit by treatment, and these cases were considered for suspending treatment and were defined to be futile lesions where you could give a treatment pause and see whether the treatment is really benefiting the patients or not. Multilayering of PED, again a poor prognostic sign, chronicity of disease, and patient may or may not benefit visually if you continue anti-VEGF treatment. Subretinal hemorrhage, repeated hemorrhage is seen very often, and if it is present, usually triggers fibrosis. And you can see this is a case of massive subretinal hemorrhage. Following treatment, hemorrhage is gone, but look at the amount of fibrosis or scar tissue which has got left behind. So this is a poor prognostic marker. RP atrophy, again, especially it can be, as we had discussed earlier, be associated with MNV at the margin or CNV at the margin, And here the number of injections have definitely to be kept to a minimum to avoid any progression of atrophy. So this I think ma'am had covered previously in her talk, so I will skip this. So are there any OCTA based markers? So OCTA, the disease activity, has been defined as presence of very tiny branching vessels, presence of anastomotic arcades, presence of inner loops, presence of a hypointense halo. And with treatment, you see the peripheral capillary tufts may decrease, the size of CNV may decrease, but sometimes if there is already maturation of the blood vessels, the larger trunks may not decrease actually. So larger the NV area on OCTA, longer the NV length, largest vessel caliber, and the MNV flow. Most of our OCT machines can give us this. You can see the MNV flow. So this may persist in the larger trunks or vessels even while in the periphery the capillaries collapse. So this should not just always be taken as a sign of activity. You need to look for the peripheral capillary tufts, whether they are present or not. You can see here, this is what they call the pruning of the vessel. The size of the new vascularization has decreased. Now, though the fluid is still persistent, I would not want to stop therapy here, because you can see very clearly that this is definitely working, because the size of the MNV as on OCTA is decreasing. And this, you can see, these are the large trunks of a scarred membrane on OCT, but the large trunks may persist. So this is not a sign of disease activity. So no need for treatment here. But you see a single little tiny vessel, you can see here, little bit of fluid. If you treat, it's nearly completely gone. So the early detection of these CNVs on Octa can help you decide. This is another case where I have taken use of OCTA guided treatment. You can see this is a scarred CNV, and here you can see still the CNV seen on network is seen on OCT angiogram. Minimal amount of IRCs comes. You may think whether to treat or not to treat, but if you look carefully on a OCT angio, you can see the small tongue which has crept up. So this is a new lesion. I would not hesitate to treat the patient with anti-VEGF injection. On PCV, these are some specific markers for diagnosis, for treatment, and for prognosis as well. Coming to the OCT markers, you can see a sharp peaked PED and decrease in the reflectivity under the polyp. These are signs of active lesions, and a good response usually results in flattening. So the presence of fluid, presence of intraretinal fluid, presence of PED, height of PED, type of PED, reflectivity of PED, presence of hyporeflective ring under the PL, these are signs of OCT biomarkers in a case of PCV. So just going to the patterns, just a couple of slides more. So they are divided into 3 patterns. So do they help us in prognostication? The type 1 is the trunk shaped, where it behaves more like a typical AMD and may need respond well to anti-VEGF injections. Type 2 is more of a glomeruli or an ill-defined kind of a pattern, and high recurrence rates and response to anti-VEGF is lesser. Type 3 is like a stick or a small ill-defined lesion. So this is how it looks like on OCTA. I'll just share one last example. You can see this is a case of PCV. So you have a polyp, but look at the membrane. You don't see a trunk here anyway. This is a large mass, a network of new vessels which is present. Patient underwent almost 4 injections, but the response was very poor. And last, deep learning, artificial intelligence definitely coming up, where we were considering parameters like IRF, PED, and SRF, but now they are actually feeding the computers the whole complete OCT scans with marked up heat maps for SRF, for atrophy, for SHREM, for ellipsoid zone, for disciform scars. So the computers are going to become very, very intelligent, and they may outperform human beings. And tomorrow you will just have to ask computer, shall I inject or shall I not inject? Thank you.
Can we take questions later?
Thank you, Parveen, for a very nice talk. And it now gives me great pleasure to invite my good friend from many years, Ranjana Mathur, who is a who had her education in Mumbai and has now been in Singapore for many years and as a senior medical retina consultant in Singapore. And she's going to give the keynote address on uncommon maculopathies, the role of multimodal imaging in diagnosis.
What might be something that we may see in clinics in macula as uncommon pathologies. So why, if they are uncommon, should we even bother to look at them? The reason being that you might see some of them in subacute and chronic phases, and if you suspect them, it actually reassures the patients to know what is the cause for their poor vision. So consider these diagnoses whenever you have any of these, and particularly when their symptoms are very vague but the vision that the patient has is very poor. What are some of these indications, diagnoses? It may be UM or epithelitis or some of the viral pathologies, and we'll take them one by one. So UM is actually very common, but not so well known. And if you look at the presentations, there are young patients who come with poor vision and morbidity that causes them to be very distressed because they can't see. And what you see at the RPE level is these exudative maculopathies, which actually resolve even without any treatment. So let's look at the natural course. They are rapid, they completely resolve, with most patients getting their vision back completely. But there may be residual hyperpigmentation at the level of RPE with some choroidal perfusion deficits, and there can be recurrences. CNVs usually can occur, but they are very, very seldom. What may be the causes? In Singapore, we have huge outbreaks of hand, foot, mouth diseases, so we see them in them. I've also had a patient that we've published in Zika and some of these other viral conditions. Recently, somebody has also published it in COVID. This is a patient, she's a young 34-year-old. She had a child who developed, she was in KG and developed hand, foot, mouth disease. She was asymptomatic, but the mother came with this hypopigmented large lesion with poor vision of 636 in the right eye and counting fingers in the left eye. Now look at the RPE. Basically, it shows you that there is this boggy, swollen RPE complex with IZ that is involved, and that disrupts the photoreceptors. And this is very well picked up on the OCT, but if you look at the FFA, it doesn't give you, and the IR, it doesn't give you the clinical picture that you see on the OCT, which basically just shows initial hyperpigmentation at the RPE with some blockage and then late mild staining. What about the left eye? She had also left eye, which was more severely involved, although clinically it did not look so bad. We observed the patient, and within 3 months, the patient went to here and with a vision of 612 from here. And same thing in the left eye. She developed RPE granularity, but the exudative changes and the bogginess that you could see initially at the OCT had resolved. When last reviewed a couple of months ago, she's actually developed six. Her vision is recovered to 6/6 with no central scotoma, but she does have persistent RPE changes, and this is what you might see the patient in with these kind of IR changes, and you may wonder what this patient had. And one of the diagnoses that differentials that you have to keep in mind is UM. Yet another patient, so this is a patient who tested positive, like I said, and resolved completely. And some other viral conditions that have described these are some of the ones that you may want to read through. What about this lady? Now, this patient also has very good vision, but persistently complains of seeing photopsias and visual loss in the temporal fields. Now, if you look at her, you really can't tell very much on the color picture, and OCT at a cursory glance will not tell you anything unless you critique it a little bit. This is her fundus photograph, and this is her left eye with a similar kind of picture in the left eye. So what is it that actually is wrong with this patient? So when this patient came to me after almost 2.5 months of her symptoms, when she was persistent, and only abnormality that I could see was this granularity in the temporal field with mild ERG changes, with nothing much, some scattered defects on the visual fields. But I was suspicious because I had seen a case like this earlier, and I persisted and I asked her a relevant question, and that was, did you have any fleeting rashes? and she confirmed that yes, she has these kind of rashes on her feet and on her trunk which are come and go, and she tested positive for syphilis. So although it did not give me any information on FFA and her color finger photograph as well as HVF, but her OCT, that mild granularity, is what clinched the diagnosis. This another patient who came 2 days of history. Again, if you look at it, his symptoms are similar to the first patient that I showed you, but her fundus photo, his fundus photo and her autofluorescence is completely different. And FFA does not show much changes, but in the later frames you can see some hyper autofluorescence, and ICG shows dense hypo autofluorescence. This patient lived in an area where we were having pandemic at that time of Zika, and he tested positive for Zika. And just like the first patient with he also recovered within the first few weeks of developing the symptoms with complete recovery. He tested negative for all other blood tests that we standard do for UMs. Then comes a second subtype of macular conditions that you see in patients. Again, young patients, usually unilateral, but they have again catastrophic central scotomas in some patients and metamorphosis in most of the patients. So what is a clinical sign that you have to look for is with this dark macular lesion, which is surrounded by yellowish hypopigmented lesions. It may look like a very subtle sign on fundus photograph, but OCT will pick it up. So you've seen a lot of these images today, and you can see that this patient is actually a nomenclature failure, because it's not RPE that is the primary source of the problem, but the ellipsoid zone. Because the ellipsoid zone outer segments are not phagocytized, they start to develop and swell up their photoreceptors, which then causes the symptoms. But the RPE, which is in the red line, actually always remains undamaged. So looking at the patient, you will see that they will ultimately have some stippling at the RP level with some yellowish halos, and otherwise very unremarkable FFA and ICG. So this is our patient. She had this RPE kind of thing, hyperreflective lesion. You can see some defect in that IZ zone and EZ that is getting disrupted with some elevation of the ELM, but the vision was not very much affected, 6/9. She was just having metamorphopsia. We look at the vasculature was not affected at all at any of the segments. And I'll show you the left eye, which then 6 weeks later, she had the right eye symptoms that disappeared, but the left eye developed 3 years later. Recently, she's come up with, again, similar kind of arpitelitis. And if you look at the segments or the cubes of deeper layer, you can see some dark lesions, which may suggest that there may be choricapillary deficit, but FFA does not show any abnormality. Another patient who may end up looking like same patient who may end up on ICG look like showing fine signs of mutes, but actually again has partly healed arpitelitis, which and her visual fields were negative. So you do need to keep that index of suspicion, because as this arpitelitis heals, it causes EZ to enlarge, but the hyperreflective lesions to resolve, and they may sometimes have persistent symptoms, but some of them actually have none. Some of the masquerades of these arpitelitis, which I think all of us have seen in our clinics. First one is solar. If it is unilateral, consider it may be a dominant eye which has looked at it, but usually it's a bilateral and does leave a permanent deficit in a patient may have central scotoma. Again, a yellow spot like the arpitelitis that you see. What about poppers? I'm not sure whether it's common in India, but in Singapore it's very rare. This patient is picked up from the publication, but I had one patient who had come from Bangkok and had similar kind of thing. They resolved very well with stopping the drug and with have no visual deficit. What about the phenotype? Sometimes they have partly healed this kind of boggy lesion, but if you look at some of the others, they may have this kind of a changes which you see in some other pathology, which I'll show you very shortly. So in this last minute, laser-induced maculopathy is also something that you may want to look for this patient who had a similar phenotype like the one that you see in paupers. He's a 47-year-old gentleman. He had a bilateral suboptimal vision which lasted several years. So I had first seen him in 2008, and then he again presented it with and had similar central scotoma. So this is not like the paupers or some other fleeting viral condition where the symptoms may resolve, but basically has genetically proven occult macular dystrophy. So just to remember that all these patients look so similar but have different pathologies. Like this patient is a dual pathology, and this is something I would want the panel also to comment on. She started off with showing signs of RPE epithelitis, and this is in 2012. And she then defaulted follow up and then came again in 2018. And I've seen her recently as well. And look at her pictures. And I just want you to critique some of the signs here. This is the 2018. She's also a diabetic, so she's showing diabetic changes, but she has that interning vessel. She has that little bit of crystal changes happening, and shows picture that we see in advanced cases of PFT. But in a span of 6 years is something that I have not seen commonly. So you could sometimes have the dual pathology, and I think I'll end here in interest of time. My last case was anyway dengue, which I think all of us you know about. So thank you very much, organizers, for
Thank
giving me
you.
this opportunity to share my.
Thank you, ma'am, and those were very interesting cases. Thank you. So I'd like to thank my panel over here who's done a great job, and everybody who's come to listen to it. Thank you so much for attending the IC. Thank you. Give a quick photo.